one of the things that has been an opportunity over the last 2 years has been the opportunity to actually begin to gain knowledge around the area of acute kidney injury and what happens to patients and how do we understand how to best treat patients are just at the beginning stages of trying to understand what actually do we know about this population. And so for the next segment and the next session of our conversations today, we're going to start by asking Dr. Lorien Dalrymple to give you the first worldwide large cohort experience from multiple sites on a national scale about what we have learned about acute kidney injury. And following that, I hopefully will have a robust discussion about what kind of questions that raises. And so, Lorien, we're looking forward to your comments.
So good morning. I'd also like to thank everyone who's attending in person today and also remotely. We're going to talk about our experience at Fresenius with acute kidney injury managed in the outpatient dialysis setting. And before I begin, I really want to acknowledge Norma Offson, who will be joining us on the panel, but it was her team that really led the analytical efforts we're going to share with you. And it's been a tremendous undertaking. So thank you, Norma, and your team. And we'll get to hear more from Norma once we start the panel discussion. So just as a brief background and to frame our conversation today, as many of you know, on January 1st, 2017, CMS implemented a policy that allowed for Medicare beneficiaries with acute kidney injury to receive their care in outpatient ESRD facilities. Up until this point of time, very few studies have actually looked at the clinical course of AKI once it's managed in the outpatient dialysis facilities. As all of the nephrologists know, the vast majority of our literature really focuses on AKI in the hospital setting. And the few studies that have been done to date have been single center with cohorts ranging from 100 to a few hundred. And some of you are probably familiar with those. The UVA experience, Mayo, Michigan really recently published their experience. But beyond that, and an abstract from the Cleveland Clinic, we do not, as a community, have a very large understanding of what acute kidney injury managed in the outpatient setting looks like and what the clinical course is and what the prognosis is. So with that in mind, we wanted to take a deeper examination of the patients who are under our care to try and understand the early clinical course of AKI. So first, I just want to describe to you the cohort we evaluated to give you some context. So what we did is we looked at all patients who were initiating dialysis with a diagnosis of acute kidney injury over a 1-year time frame. And our period of study was April 1, 2017 through March 31st, 2018. All of the patients we're going to talk about today were receiving in-center hemodialysis. So that resulted in a cohort of more than 9,000 patients with acute kidney injury. To give you a sense of where patients were receiving care, these patients were being treated for AKI in more than 2,000 of our facilities throughout the US. And you can see there's very broad geographic representation. So this is quite different than what's been previously published. We also wanted to understand, on average, how many patients per month were we admitting with acute kidney injury. So the first graph, the bar graph, is simply showing you that on average, we were starting about 600 to 900 patients per month on dialysis for acute kidney injury. And those are the blue bars. The yellow bars are how many patients are we starting newly on dialysis with end-stage renal disease in-center. So we're focused exclusively on incident ESRD in-center. And what you can see in the circle graphs on the right is we started more than 9,000 patients with acute kidney injury and about 36,000 patients for incident ESRD, meaning that about 20% of patients we were starting on dialysis had a diagnosis of AKI. And this is something we'll hopefully have the opportunity to talk a little bit more about on the panel. So we wanted to preliminarily describe the baseline characteristics, and as Frank's already alluded to, these are very early initial descriptions of this cohort. I imagine we will raise more questions than we will answer today, but we want to at least give you a sense of the cohort. So patients with acute kidney injury, on average, were 63.3 years. And to compare that to the incident ESRD cohort we showed you, those 36,000 patients that were starting in-center hemodialysis, you can see the ages are fairly similar. The distribution of genders were very similar when you compared AKI to ESRD, with 42% female and 58% male. We also wanted to look at baseline vascular access, and although I know this is not a surprise to anyone in the room, this is important to remember as we start talking about clinical parameters in this population. Nearly 98% of patients with AKI were dialyzing through a catheter when they presented to our clinic. And this is quite different even compared to incident ESRD, where that number is slightly higher than 67% and nearly 20% have a fistula. We wanted to look at the initial dialysis prescription because we actually didn't know. Were most patients with AKI dialyzing 3 times a week, or was the frequency more variable in the setting of AKI? And what we found is 96% of patients with AKI were dialyzing 3 times a week. A very small percentage, 2%, were dialyzing twice a week. And we just show you the distribution of incident ESRD for comparison. We also wanted to look at treatment time, and the mean treatment time for patients with a diagnosis of AKI was actually 223 minutes. And when we talk about prescribing an AKI, we can talk more about frequency and duration and how we balance all of these things. But for comparison, the mean treatment time for incident ESRD was 216 minutes, and we provide the standard deviations for you. So next we wanted to look at clinical parameters, and we were really focused on the first 90 days of acute kidney injury. And we wanted to look at things that we as nephrologists are all interested in. So dialysis adequacy and electrolytes, bone and mineral metabolism, anemia, residual renal function, volume management, and vascular access over time. So for the purposes of these analyses, we followed the entire cohort for up to 90 days, or until someone recovered kidney function, transitioned to ESRD, was discharged from FKC or lost to follow-up, or was withdrawn from dialysis. And I want to go over this graph just to orient you, because what we did is we looked in 30-day time periods. So we looked at days 1 through 30, and in those first 30 days, we had more than 9,000 patients. If you then go to treatment period that includes days 31 to 60, we have over 5,400 patients actively admitted for acute kidney injury, but only about 4,800 receive at least one dialysis treatment during that time frame. So when we're trying to look at laboratory values and access type, we need to have at least one treatment. But when we look at outcomes, we look at the whole cohort, so all 5,410. And then by days 61 to 90, we have a little over 2,700 of those initial 9,000 patients who still have a persistent diagnosis of AKI, and about 2,400 receive at least one treatment with us during that 30-day period. So I want to take a moment to orient you to this graph, because we're going to have a number of graphs that look like this. On the left y-axis, it's the single pool KT over V value. And on the y-axis on the right is the number of patients who had that measurement during the time period. So the blue line is just there to remind you that over time, a much smaller percentage of patients are available for study. And so those averages reflect the population during that time period. So if we look at the single pool KT over V in these different time frames, you can see on average they range from 1.5 to 1.6. And the error bars simply represent plus or minus 1 standard deviation. And that's true of all of the slides I'll show you. If we then look at albumin and potassium concentrations, again, similar orientation. The right axis with the slightly darker green and blue lines is just showing you the number of patients who had that laboratory measure during the time period of interest. And the left axis is the albumin or potassium concentration. So the mean albumin concentration in the first 30 days was 3.2. In the subsequent time frames, it was 3.4. The potassium concentrations on average range from 4.3 to 4.4. We also looked at bone and mineral metabolism parameters, and what you can see is the calciums on average range from 8.7 to 8.9, phosphorus is in the mid to high 4s, and the mean PTH ranged from 288 to 302, but had very large standard deviations. We also wanted to better understand anemia, so we just started by looking at the usual parameters. So if we first look at mean hemoglobins, you can see in the first 30 days, the mean hemoglobin is 9.3. In days 31 to 60, 9.9, and then in the latest time period, 61 to 90, the mean hemoglobin is 10.5. The orange line is just showing you, my apologies, the TSAT. So it starts out with an average of 22, 26, 27, so higher values in later time periods. And there's a similar pattern for the ferritin, the blue line, with a mean of 607 in the first 30 days and 686 in days 61 to 90. We wanted to further examine the administration of iron in the setting of AKI. So we looked at the mean dose of Venofer among recipients of IV iron. So the mean dose in the first 30 days was a little over 600 milligrams. This is a total dose, total administration during the time period. And then in the later time periods, the mean total dose was a little over 400 milligrams. And I just repeat those ferritin and TSAT values so you can see those plotted against Venofer administration. We also wanted to look at ESA use. So I want to take a minute to orient you to this slide because I know there's a lot of different information. So on the left y-axis is the mean Mircera dose per hemodialysis treatment. And we can talk more about that during the panel. I'm looking at Norma because she can tell you about all the ways we try and think about ESA utilization. The treatment periods are slightly different on this slide simply because of the way we prescribe Mircera. And I will mention before going on any further that we did also look at darbepoetin and other ESAs, but Mircera was the dominant ESA, so these are the findings we'll share with you today, but we do have that other information available as well. So we wanted to look at the mean Mircera dose in AKI, and the best population we thought to compare the dose to was incident ESRD. So that same incident ESRD cohort starting in-center hemodialysis I showed you at the beginning is the green boxes where we have the ESRD mean Mircera dose. The number of patients receiving Mircera are in the green dotted line or the blue dotted line, but we've put the labels for the number of AKI patients just to give you a sense and make that a little easier to read. So in the first 28 days, more than 4,300 patients with AKI received Mircera. In the next 30 days, it was more than 3,500, and in that last treatment period, it was a little over 2,000. And what you can see is that the mean Mircera dose in AKI per hemodialysis treatment ranges from 15 to 17. And if we compare that to incident ESRD, the range is more in the 11 to 14, depending on the time period. We did want to look at measures of inflammation for a number of reasons. First, this is acute kidney injury. Second, there's a very high prevalence of catheters. We are presuming there have recently been acute severe illnesses that may have contributed to the development of AKI. So we looked at three things: albumin, ferritin, and neutrophil to lymphocyte ratio. And the albumins I've already shown you, as the ferritins as well, but I just put them back on this graph so we have them all together. So what you can see is the mean albumin is 3.2 in the first 30 days, and in subsequent periods, the average for the remaining population is higher at 3.4. The ferritins increase over time, but we've already discussed that Venofer is being administered, so ferritin can be difficult to look at in the setting of administering IV iron. So we added on the mean and median neutrophil to lymphocyte ratio, and what you can see is in the first 30 days, the mean neutrophil to lymphocyte ratio is 8.6. The median is about 5, so we have extreme values that can influence the mean. In later time periods, the mean NLR and median NLR are lower for the remaining population. We wanted to examine residual kidney function, and so for this slide, I want to first orient you to the right y-axis. So this is the number of 24-hour urine measurements we had available. So you can see in the first 30 days, it's more than 1,200, but by the last 30 days, it's less than 500. But among those with available urea clearances, I show you the median values in yellow. So the median urine urea clearance ranged from 4.8 to 5.3 depending on the time frame. And we also show you the median serum creatinines in green, and that was generally ranging from 4 to 4.3. We also looked at total urine volume, and we had a slightly higher number of total urine volumes. So again, the right y-axis is how many 24-hour urine measurements are contributing information during this time period. You can see we have more than 2,000 measurements in the first 30 days and a little over 500 in the last 30 days. But the median urine volume among those, with urine volume being measured and submitted as a 24-hour urine, is ranging from about 1 liter to 1.1 liters. So again, this isn't the entire cohort, but among those who do complete 24-hour urines. So we next looked at UFR, and this is another complicated slide. You can tell we're trying to put a lot of information in to a relatively short presentation. So let me orient you first to the y-axis. So that's treatment period. And so it's turned around from all our other slides. So days 1 through 30, 31 to 60, and 61 to 90. The green bar is the first one to look at. So this is the overall UFR during that treatment period. So the average UFR in the first 30 days is 4.9 mils per hour per kilogram among patients with AKI. In the next 30 days, it's 5.5, and in the last 30 days, it is higher at 5.9 mils per hour per kilogram. We then wanted to look at UFR by treatment time. So that's what all the blue bars are. The lightest blue bar is a treatment time of 270 or more minutes, and the darkest blue line is less than 150 minutes. And what you can see is almost this bell-shaped curve that the highest and the shortest treatment times have the lowest UFRs on average. And again, I think this will be a topic for our panel discussion, and I imagine we can all come up with different reasons why this would be true. But we did want to try and understand UFR by treatment time and also by urine volume. So this is UFR by urine volume. So what we did is we looked at urine volumes that were available in the first 30 days and then looked at UFR by that urine volume. And what you can see is among patients with less than 1 liter of urine, UFRs tend to be on average 5 to 5.4. If you compare that to patients who have urine volumes of 2 liters or more, the UFRs are much lower, in the 3s, on average ranging from 3.5 to 3.8. And again, I think this is what most of us would have anticipated, but we wanted to confirm that by looking at the data we had available to try and understand how UFR is being influenced by treatment time and residual renal function. We also wanted to understand management of dry weight in the AKI patients. And I think this will, again, raise more questions than it answers. But the first question we asked ourselves is what % of treatments are patients within 1 kilo of their dry weight? So within 1 kilo, within 1 above or 1 below. And that's the green bar. So this was actually the first thing we did. And what you can see is less than half of the treatments were patients within 1 kilo of their dry weight. So then, this was a meeting many months ago where a number of us were sitting around and we said, well, do we think they're above or below their dry weight? Because this is AKI. So that was the orange and yellow part. So that was the second step. And what I want to point out is that the majority of treatments that were not within range of dry weight were treatments where people were more than 1 kilo below their dry weight. So this is probably different than how we typically think about, for example, treatments in ESRD, but you can see over time that changes. So in the first 30 days, we see about 1/3 of the treatments below dry weight by more than 1 kilo. But as time goes on, that number changes. And I think this likely reflects some of the complexities of management of volume in AKI and trying to avoid volume depletion or challenging dry weight and how people might be trying to prescribe to achieve euvolemia or maybe even mild hypervolemia in the setting of AKI. As I mentioned, we wanted to understand vascular access and whether it was changing over time. Nearly everyone started with a catheter, but we didn't know how this changed during the course of AKI. And again, these are individuals with a persistent AKI diagnosis. So if you've transitioned to ESRD, you're not included here. So that's an important background to keep in mind. But if we looked at what was the access type for your last treatment in that treatment period, we could look at how many patients were completing their last treatment with a catheter. So in the first 30 days, it was 98%. In days 31 to 60, it was 97%. And by days 61 to 90, 95%. So we then asked, well, among those using a catheter, how many have a fistula or graft present? And what you can see is even at days 61 to 90, a very small percent of patients with a catheter have a fistula or graft present, about 4.3% in the period of 61 to 90 days of AKI. So then we went on to examine outcomes. And for this, we wanted to, again, assess outcomes in 30-day treatment periods. So we divided times into 30-day windows. And for each of those time periods, we looked at recovery of kidney function, transition to ESRD, death, or persistent AKI. For these analyses, we actually went out 150 days. We wanted to go out as far as we could to better understand outcomes in this population. And we used similar rules to the last cohort, although we stopped evaluating people on June 30th, 2018. So we followed all individuals until June 30th, 2018, or until they recovered kidney function, transitioned to ESRD, were discharged or lost to follow-up. So in the first 30 days, we know we started with over 9,000 patients with acute kidney injury. And if you look at the first 30-day time window, what you can see is 6% of individuals die, 18% recover kidney function, 12% transition to ESRD, and nearly 60% have persistent AKI. A very small percentage, 4%, are discharged or lost to follow-up. So those 59% with persistent AKI become the group we look at in the next 30 days. So in days 31 to 60, we asked the same question. And during this time period, 5% of patients died, 20% or 21% of recovered kidney function, 21% transitioned to ESRD, and about half had persistent AKI. If we then look at days 61 to 90, you see some similar patterns, except for a much larger percent are transitioning to ESRD, but about a third are still considered to have persistent AKI. So if we look at that third, those 894 patients who have persistent AKI for more than 90 days, what we see is ongoing recovery of kidney function. And this actually ends up being about 16% of the 894 patients recover kidney function in this later time frame. We see ongoing transition to ESRD. And this is another way of showing the same information but cumulatively. So these are 90-day outcomes. So after 90 days of outpatient therapy for AKI, where day 1 is your first day of outpatient treatment, we had about 6% of patients who were discharged or lost to follow-up. 10% of patients died, about a third recovered kidney function, a third transitioned to ESRD, and nearly 10% had persistent AKI. If we re-ask this question after 150 days of follow-up, you see a similar percentage of discharge or loss to follow-up, a little over 7%. The 10% die, a third recover kidney function. Now about 44% have transitioned to ESRD, and a very small percentage, less than 1%, are considered to still have acute kidney injury at 150 days. So in conclusion, we found that during this 1-year study, almost 20% of the patients we were initiating on in-center hemodialysis had a diagnosis of acute kidney injury. When we looked at 90-day outcomes, we saw that about a third of patients will recover kidney function within 90 days, and about a third will transition to ESRD. Among those individuals who have sustained AKI for 90 days, 16% will go on to recover kidney function in the next 60 days.